Welcome, everybody. My name is Michael Lucy. I'm a professor of medicine at the University of Wisconsin. And nowadays, I'm almost always the oldest person in any group that I meet. So I'm old enough to remember when liver meetings had alcohol-related liver disease in a phone booth somewhere in the conference center because there was so little interest in it. So it's really encouraging to see such an interest in this session here and in alcohol-related liver disease throughout the conference. We're going to have a session here called Supporting Patients with Alcohol-Associated Liver Disease. This session will review the multidisciplinary management of alcohol-associated liver disease, focusing on the psychosocial aspects of care and destigmatization of the disease. And my co-moderator is Jessica Mellinger, and she will introduce herself now.
Hello, everybody. Ooh, hi. It's nice to meet and see all of you and see such a packed crowd. This is great. I think it's always great to see a packed crowd for a session devoted to our patients specifically and the patient view and the patient experience. So thank you. I'm an assistant professor at University of Michigan where I do research and clinical practice in ALD, and I'm going to be the shortest talk today. I hope I should be. Tug on your earlobe if I'm going on too long because we want to get to our speakers. But I'm going to give a quick overview of just the landscape of ALD, where we are today, and kind of how some of what we'll hear fits in. So I think it's no surprise we all know the epidemiology of this disease in the United States and also in some areas as well elsewhere globally, that it's really going up. You know, I could show a giant up arrow for this slide, and that would basically explain it. Pre-COVID, ALD rates, certainly here in the US and also in some areas globally, were going up over the course of decades, including mortality for ALD, seeing it again in younger people, more women. In the COVID world, after COVID started, those rates kind of skyrocketed. We saw the slope of that line get even more steep. Increases in transplants, waitlisting here in the US at least for alcoholic hepatitis. And some of that has leveled off now that COVID has kind of also leveled off. So kind of leveled off back to the curve that it was at before COVID started. So we're still rising. And we know that there are certain influences on this besides dose of alcohol, besides the increasing alcohol use rates that, again, we see certainly here in the US, but also sex, race, ethnicity, and genetics play a big role in that. So research has really been focusing on some of these factors. But what happens to people who have ALD? And I will say that this is often a question for many of my patients. What's going to happen to me? Especially if they survive an episode of ALD, severe episode of ALD, if they survive and they have cirrhosis and they're moving forward. This was a great paper that came out of Denmark looking at the long-term consequences, the long-term mortality for patients who are diagnosed with ALD. And it isn't always just liver disease. Certainly this is the largest portion kind of in that, what is that color, peach? Brown, I can't tell, at the bottom, but usually liver's green, but it's not here. But you can see here that other cancers are really important. Death from alcohol use disorder itself, cardiovascular disease, infection. So it really behooves us to think about not just the liver, even though we are a liver society, it is the best organ, right? To really think about our whole patient and the fact that alcohol impacts their whole body, not just their liver, and that has mortality implications for how we think about caring for survivors. What's happening here in the US and what can we do about it? This was a modeling study that looked at what would happen if we didn't do anything about alcohol use rates. In the gray bars, you see mortality going up through to 2040 and beyond, death, disability continuing at just the same rate. But if we were to implement national-wide population-level interventions that brought alcohol use back down to year 2000 levels, we get the blue bars, a slight reduction. If we are even more aggressive and we reduce it even further, we get the red bars. So this is where we need to be thinking. What can we do to get us into the red here? What can we do as we go forward from a policy standpoint, just with our patients, to reduce the prevalence of this as time goes on? So again, what happens in terms of drinking for folks who have compensated This is cirrhosis patients. So this is the CIRAL study, a prospective study of biopsy-proven alcohol-related cirrhosis patients who are compensated. What happens drinking-wise? So you can see that the majority of patients who are abstinent remain abstinent. This is called, and I love this, this is called a lasagna plot. Isn't that great? Anything that talks about food, right? All right. So this is called a lasagna plot, and on your left you see those who are abstinent, and you can see that about a third may drink again, but it's variable, right? Some will go to high levels, then to lower levels, then to abstinence, then to back to high levels. Some will taper off over time. And this puts us in mind of personal patterns of recovery, right? There are patterns of recovery that are individual to our patients. Some people go to abstinence right away. Some people stay there once they are abstinence. Others go up and down and eventually get it. And as you can see here, for our non-abstinent patients, even those who are drinking the most heavily, at follow-up, many of them reduced or became abstinent. So there's a great deal of hope here for patients who come into us even with advanced liver disease, which is important. How do we care for these patients? Increasingly and very fortunately, we're hearing more and more about the importance of integrated care. Dr. Weinreib's going to speak about some of the really innovative work they're doing at University of Pennsylvania today, and I'm excited to hear about that. And we know that it works. So this is data, a meta-analysis that was performed by Dr. Alfaki and colleagues. It was published this year that showed that integrated care, and this is in a liver transplant program, but in non-liver transplant we see similar data, reduces mortality and reduces relapse. What else do we have that reduces mortality in this population? Right? Not a lot, but this does. And so we really need to be focused on this. For those of you who don't have a co-located transplant center, ALD clinic, that's okay. Integrated care happens at a variety of levels, as you can see here. My colleague, Dr. Scott Winder, who's our transplant psychiatrist, put this together and has done a lot of really groundbreaking thinking on integrated care in this space, is that it starts with maybe being totally unaffiliated with an alcohol use disorder program, but asking your patients about alcohol every time, using your audit scores, and then building from there. If that's what you've got, that's what you've got, and if that's what you're doing, that's great. And then as opportunities arise to integrate further and further, then we take those opportunities and our patients improve. And then this study was done this year, published this year from Johns Hopkins. Dr. Chen, Poing Chen performed this study, and I love to see qualitative work. Qualitative work is hard to do. It's interviewing patients. It often doesn't get published in high-impact journals, though it should, because this is precisely the kind of patient voice that we need to be hearing about. What is the experience of having alcoholic hepatitis like, and then going through that transplant process? I won't go through all of this, but as you can see, there are a lot of themes here about what it means to have this, what it means to be diagnosed with ALD, how that feels, how it feels to really have this severe illness, to be asked to do things around the time of transplant that may be quite difficult because you have advanced liver disease. It's hard to think you have encephalopathy, but yet we're demanding very cognitively demanding things of these patients, like therapy, managing lots of medications, et cetera. This is really important work that I hope everybody goes to this paper and reads it, because this is a really clear, very important patient voice that we need to be focused on into how we can help our patients more. And then finally, just as we think about kind of how to structure our thinking about reducing alcohol use for our ALD patients, it can be a little overwhelming, right? This is a big problem, alcohol use in the US and in the world. How do we think about how to do this? So in the behavioral research world, when we're thinking about changing behaviors, it's complicated, right? We often have to do multiple things. It's not like a typical randomized control trial where both populations are the same, we change one thing and we see what happens. Behavioral research requires multimodal interventions, and so this model, which is called the social ecological model, encourages us to think about all the different ways and levels at which we might be able to intervene to reduce alcohol use. Whether at the individual level, again, you ask your patients about it, you talk to them about it in a motivationally interviewing way, and you try to refer them to treatment, you're doing it. You're getting it done. And then as we think about how to expand that into our own healthcare organizations with solutions, research programs, public health efforts, et cetera, all of this working together will really help to kind of turn the tide on this in the US and globally. So with that, I'll stop and I'll turn it over to I think Dr. Weinreib is next, right?
So our next speaker, yeah, thank you very much, Jessica. Two quick comments. One is, if you have a question occurs to you, hold it, because we're going to have a panel discussion at the end of this, and we will try to give you an opportunity of expressing all the thoughts that you have and hear our panelists' response. The second is there are one or two chairs available, but they're hard to find. So in an exercise in social organization here, if you could move in towards the middle and leave the chairs on the outside vacant, then the people on the sides could see where they are. That would allow more people to sit down. So while this movement is going on, it gives me great pleasure to introduce my good friend and for many years collaborator, Bob Weinreb. Bob is a professor of psychiatry at the University of Pennsylvania and has many years been involved at the interface between the care of patients with alcohol use disorder and patients with liver disease, and has been a key figure in building the notion that these two disciplines can work together. So thank you for coming today, Bob.
Well, thank you so much for having me. Does everybody hear me okay? So really grateful to see all of you out there. I think when I was talking to Michael about doing this, he said, well, there could be 3 people or it could be a packed house. So happy to see it's a packed house and that I can be your token shrink. Thank you. Sure. So we're going to talk about challenges in the psychosocial management of alcohol-associated liver disease. And I was told that a portion of this talk would really be geared toward people who were not professionals but were patients. And so some of this might be a bit redundant for those of you who are on the forefront of treatment. Disclosure, nothing there. So the objectives of this talk today is to define the role of the transplant psychiatrist in the care of alcohol-associated hepatitis. The second thing, there are 3 objectives. The second one will be to review some of the main challenges that we and patients face with this disorder and how we as psychiatrists manage them, and now psychiatrists and hepatologists, thank you. Talk about groundbreaking. We're going to describe 2 alcohol treatment programs that we started at the Penn Transplant team, primarily for the focus on alcohol-associated hepatitis, and I'll explain why that is in a little bit. And then really the other question is, how transferable is that? So in other words, can you guys do this at home, so to speak? So I'll start with a cartoon because that's, you have to do that. So let's pretend I'm at a party or whatever, dinner, I'm meeting new people, and they're always like, what do you do for a living? And I go, I'm a psychiatrist. And then they say, oh, are you in private practice? And I say, no, I'm a transplant psychiatrist. And then they look a little bit like the child hot dog here on the far right, where the parents are explaining, and that's where hot dogs come from. And that's sort of how it feels when I try to explain to them what it is I do for a living, because it is so multifaceted and changing at all times, which is kind of what I love about it, actually. So they usually say, I've just never heard of that, and why do you need a psychiatrist in the first place? I'm like, okay, I'll tell you, got a week? So let's go over these objectives one at a time. The first objective is our role in transplant psychiatry, and what do we do? As you know, early liver transplant precluded the whole 6-month rule process, although I have to tell you at Penn that we really never followed the 6-month rule because the data that was supporting it was fairly weak. And we felt that each person as an individual had to be dealt with on their level, and that we weren't going to be using strict guidelines, and to this day we still do that. But you do need a comprehensive psychosocial evaluation because these are folks who, for the most part, have had very little, if any, sobriety, and they've also had almost no exposure to AA or treatment for their alcohol use disorder. So we start by introducing ourselves to the patient and family, and we explain that we evaluate all new patients who have a history of psychiatric, drug, or alcohol problems that could affect the care of the newly transplanted liver. And that our role is to try to create a treatment plan or a pathway for transplant for you in order to maintain your health and your success going forward. So we are not actually the Roman emperor. That's really everybody's fear. If you're a patient and you're meeting the transplant shrink, your first thought is, oh, this is the guy who's the gatekeeper, this or this. And that's not why I went into this. I couldn't do it if that's the case. And so, I'm very explicit with them about my job as an advocate for them. Furthermore, we indicate that the reason we're doing this transplant evaluation is because we're one member of a very large multidisciplinary team. And so all of the stuff that we talk about is going to be shared with the transplant team. And this is something that I really, really hammer home with my residents and my medical students, because if you forget that, you're really broaching an ethical no-no with patients. They have to know why you're there and what it is you're asking them these questions for. You can't sort of come at it sideways. So decisions about wait listing, as I said, are made by the entire transplant team, and we look at these risks as more or less equivalent. So medical risk, surgical risk, psychiatric, social, financial, all of these things go into the mix about decisions regarding, how to help a person get listed and stay healthy. What we will then do is try to attempt a comprehensive interview for the candidate and discuss and look for, psychiatric disorders and also risk factors for any post-transplant use of alcohol, drugs, and/or nicotine. We do that by identifying barriers to adherence to medications and follow-up and appointments, and then we provide a guideline or treatment plan to the patient, the family, and to the transplant team. One of the things that we've done at Penn, which I'm kind of proud of, is I explain this to my patients. I'm like, if you have trouble with sobriety and you are being evaluated for listing or you are listed and you tell us about this, this does not mean that you're going to be removed from the list. You might be put on inactive status until such time as we can kind of boost up your support and get you back on track. But I want you to feel like you can actually tell us that you're having some trouble, because let's face it, alcohol use disorder is a chronic relapsing disorder. It is not a whole heck of a lot different than hypertension or diabetes or even asthma, because none of those disorders have cures, but they're all pretty treatable, but they also come and go. So what are these challenges that we face? We saw a huge increase in the number of patients with short sobriety needing early liver transplants starting in about 2019, 2020. And of course, we weren't the only ones seeing this. This has happened globally. What we also saw was that patients were younger and there were more females than before. We would see maybe from a psychiatry standpoint, 3 or 4 alcohol-associated hepatitis patients, maybe over a year's time. We were seeing between 2 and 4 a week after COVID. And then instead of being in your 50s and 60s with cirrhosis and hepatitis on top of that, these were folks in their 30s, 40s, small children. The youngest I evaluated so far was 24. I think probably somebody out there could beat that, which is not something to be proud of, actually. But what I am saying is that without, I think, the societal oversight that comes with family, with jobs, with not being isolated, these people are at great, great risk. And we never saw that before, so we had to respond to that. As I said, very few of these patients had ever had treatment for their alcohol use disorder or ever been to an AA meeting. And understandably, when you say to them, we really want you to do this after a transplant, are you okay with that? They're going to say, yeah, because the stakes are like, okay, if I don't do that, then I guess I don't do much of anything else for a very short time. So the transplant teams in psychiatry have a very short period of time in these cases to make decisions. And it takes us a lot longer, usually, than the 24 to 48 hours that we are then given to provide clinically relevant information about risk factors for these folks. So how do we get this information? Especially because so many of them are unable to participate in the interview due to encephalopathy or just severe illness and fatigue. And so we reach out to family members. We reach out to mental health providers if they have them. We talk to outpatient PCPs. We talk to GI doctors. We get as much collateral information in that short period of time as we can, and then we look for the areas that need strengthening and go from there. There are special concerns, however, regarding talking to family members about what they think their loved one is how they're gonna do with a transplant, right? You're really putting them in an awkward position. Some would say untenable, of course, and understandably, there's some ambivalence. You don't expect family members to come around and say, you know what, my sister should definitely not get this liver. I think it's time for her to go. We don't see that too often. And if we do, that's a real big question. Like, okay, is it the sister or the other? Who's got the problem here? But in any case, so we don't want to put families in a very awkward position. And so we're careful to explain to them, again, what our role is, and that we're using this information to try to create this pathway to transplant. So what we do hope and kind of expect is that patients and families will partner with us and the transplant team so that we can manage this together after the transplant. So now I'll give you an example. This is a gamish of a couple of different cases with a lot of the information sort of switched around, so there's no way to identify this person. But in this case, it's a 40-year-old married female healthcare professional with 2 small children. She presented with severe alcohol-associated hepatitis and on top of cirrhosis and complicated by renal failure, and her last drink before we met her was 6 weeks prior. She has a history of an upper GI bleed due to alcohol consumption that she was made aware of about 6 months before that and was told that she had cirrhosis and she was advised to stop drinking. She did try. She joined a faith-based recovery group, but only for a short time because her childcare situation was really on her shoulders, and she couldn't do both, especially with working in the field of healthcare. So psychiatric evaluation came up with a diagnosis of major depressive disorder and partial remission. She was on some medications from a primary care doctor. So she's not out there just flying, flapping in the breeze. She has people who are working with her and caring for her, like her primary care doctor. She also had a husband, but not too many other family members were involved. She had a history of a panic disorder, and we diagnosed post-traumatic stress disorder in her from a lot of emotional and physical abuse from one of her parents. And so what did we do with this information? How do we use that in terms of our decision making? First, we sat around the table as we always do, and we said, this is a young mother of small children. And so there are very real and understandable concerns about leaving those children motherless. And then the other thing is that she did try to get into an alcoholism treatment program and therefore acknowledged that she had an alcohol use disorder and did agree to go to treatment, especially if we could help somehow with childcare. This prior undiagnosed post-traumatic stress disorder had never been treated, and so in our view, if we could provide adequate treatment for that, perhaps she'd be far less likely to relapse. And if she did have a slip, and we distinguish between the two of them. By the way, in AA, slip is like sobriety loses its priority. And the relapse is really loss of control over falling back to drinking. Either way, we want to push it in the direction of abstinence as best we can. So the presumption is that if she was adequately treated, there would be less risk of relapse, and the final decision was, in fact, to list. So we responded by our seeing this increase in 400% of patients receiving liver transplants for alcohol-associated hepatitis at Penn by creating one program which led to another. And the first program we called Penn Total Recovery. And it was a quality improvement initiative to improve treatment adherence and reduce relapse in this extremely high-risk population. We set it up as a 12-week intensive outpatient program, a little bit different than some 12-week programs that are like typical IOPs are 3 times a week, 3 to 4 hours a day. This was once a week for group for an hour and a half and individual therapy for a week. And actually patients were allowed to be flexible. So if they didn't want to do group or individual, they could choose not to do that, but they had to pick one. I think what really made this special for our patients was that we had a very, very well qualified alcohol counselor who was actually studying for her PhD and had a master's degree in alcoholism care. And we made this group exclusively for these patients with alcohol-associated hepatitis. And those of you who know what it's like to work with a lot of these patients, they really feel for a lot of reasons that they don't belong in the community of alcoholism treatment. They don't feel like going to AA is right for them. They don't feel they fit in. And also a lot of them feel like they're stopped drinking on their own and they're proud of that, and so they don't think they need any further help. As a result of that, we put this together, and it was based on 12-step facilitation, motivational interviewing, and cognitive behavioral therapy. And I didn't put a slide in about all the way it's broken down, but the counselors basically had modules. Each therapy session had a specific theme and topic that was gone over. So for example, one might be, how do you deal with being at a party? How do you have sober fun? What is an AA meeting and why do you go? Those kind of things. The second program is called iLearn, and this was modeled in some respects after what Dr. Mellinger did with Dr. Winder at Michigan, and we started this in August of 2023. It's a co-located, fully integrated, multidisciplinary clinic with hepatology, psychiatry, social work, and addiction medicine to manage folks with this problem. I guess I was doing this when I met Dr. Lucy in somewhere around 1995, but we didn't have a name for it. Basically, I was trying to recruit for my study, and I figured it was a lot better to just be sitting there with the hepatologists, working with them shoulder to shoulder, and that's kind of how this career got started for me. So the goals were to provide comprehensive support for people going through this, both pre or post-transplant patients, to increase the number of people with high-risk alcohol-related liver disease who are deemed appropriate transplant candidates, and to maximize the likelihood of their maintenance of sobriety, rates of survival, and overall health outcomes. So I'll give you a little bit of data that we have. So this is the Penn Total Recovery IOP. As I said, there are really two different groups. The one that I mentioned, the Integrated Liver Transplant Engagement and Recovery Network, which is the second one on the bottom of the slide, is really, we just got it started. And so we've only had about 7 clinics. We have 4 pre-transplant patients and 8 post-transplant patients, and really have no outcomes yet, but we're gathering them. The other group, the Penn Total Recovery Group, has actually gone through 9 cohorts of 12 weeks of treatment. We are presenting, this data is just on the first 3 or 4. It takes a long time to kind of put this stuff together. So there were completers and non-completers. There were 24 completers and 10 non-completers. And when I say completers, I mean that they went through at least 8 to 10 of the 12 weeks that were laid out for them. And the percentage of people who drank anything, doesn't distinguish right now between slip or relapse, was 20%, so 5 out of 24. If you look at the non-completers, it was 60%, 6 out of 10. But when you really want to look at is the disposition of these patients and what really happened to them. And so in our group of completers, only one really got into serious trouble, was lost to follow-up. That's 20%. And the rest of them, 80%, 4 of them, are currently in remission and continuing on in treatment. In the non-completers, unfortunately, 3 of those patients passed away, 50% of the group, and 3 of them continue to drink now. So to summarize, our role in transplant psychiatry is to develop this treatment plan to guide patients and teams and family members on a path to transplant. One of the things we do at Penn, which is very unusual, in fact, I think we might be the only program in the country that does it, is that we take our patients on and we continue to treat them. So we see our post-transplant patients up to 18 months post-transplant for any psychiatric care that's necessary. We have 3 full-time mental health professionals doing this. Myself, one of my fellows who's been with me now for 7 years after graduating, so 2 transplant psychiatrists and newly minted nurse practitioner who's just amazing, actually. I can't say enough good things about her. And so all we do is take care of these patients specifically. Our challenges are, because of the low survival rates without transplant, these patients needed to get an early liver transplant for their problems, despite the short sobriety and the fact that they've not had any alcohol treatment exposure or AA. And I think our case demonstrates the benefits of being flexible in this complex decision-making process about waitlisting. You know, we do have something called the SIPAT, which is the Stanford interview of psychosocial assessment of transplant, which is, a cutoff, basically. It has numbers going from like 0 to 70. The higher it is, the worse the problems are, the higher the risks there are. And we advocate that that number only be used as a guideline, but never a cutoff. So how did we respond to the challenges? As I mentioned, we had the Penn Total Recovery and the iLearn. And what I put here in yellow is the thing that really struck me the most. After all the years that I've been doing this, it's so difficult to get patients to get treatment in the community for a lot of reasons. You know, getting there is one thing. Paying for getting there is another thing. You know, admitting that you have a problem so that somebody can give you a ride there is another thing. And feeling like you fit in. These patients actually love being in there together, so much so that they formed their own alumni group. And so they meet every month. They call themselves the Transplant Champions. And we couldn't be prouder of them. And they're really doing the work, if you think about it. They have a therapist at every session, but they help each other in ways that we could never have imagined. The limitations for the early evidence that we presented today is that it lacks a control group, randomized control group, that we didn't really address barriers head on to motivation and financial and insurance and transportation. These are things we're doing now. And that we didn't actually evaluate, but we did use medication-assisted therapies such as naltrexone, Vivitrol, baclofen. In the future, we're planning to use more family education because I firmly believe that the best way to treat somebody with an addiction is to not treat them in isolation, but to actually involve, as much as you possibly can, their support. Because without that, I really feel like you're kind of working with one hand tied behind your back. Think about it. These are the people that are with them every day. They have to understand what they're going through, and they can be great support to one another if they're guided in that direction. The other thing is we're going to have bedside introduction to the counselors for our patients with alcohol-associated hepatitis, and we're going to increase the use of phosphatidylethanol, which is the long-term measure of alcohol use, which is PEth. So what would I suggest to you folks? What do I think the transplant community could do at this point that might not be very expensive but might be effective? And the answer is kind of like what we fell into doing, which we didn't plan or know how successful it was going to be, and that's to train certified addiction counselors on the basics of liver disease, which is how we started that, and the liver transplant process, so they knew kind of who was walking in the door for them, and then start a recovery group with them that's exclusively for these very high-risk patients. We're waiting for the data for iLearn, and hopefully some of that information will add to this, and we'll know even more about what to do. And I think that with the assistance of psychiatry in the model of integrated care, we can work together to, I don't mean to say this, but to train you folks on how to use motivational interviewing techniques and strategies to talk to patients so that they're not put on the defensive. To understand your own feelings when you're talking to someone who's going through something like this, and to learn how that can be reflected to a patient in a constructive way, and also how to use these medications. So just to let you know, I am currently on sabbatical, which my chair calls a staybatical, and I want to thank you guys for your attention, and I also want to thank my wife for filling all available special time that I might have from this sabbatical, working with our 13 goats in her Philly Goat Project, which is basically to help children with special needs and work with a community that's been exposed to a lot of trauma. So thank you for your attention, and I appreciate seeing you here.
Thank you, that was excellent. So next up, we have Jen Jones, who is the founder for the Society for Sober Liver Survival, and she'll be introducing all of us to her concept. Thank you. Jen?
I'm like at a school, I'm going to pass a note down, so. Good afternoon, and welcome for coming here today. I'm so excited to see a full room. I can't tell you. I was like this. I was like, is it going to be 3 people or is it going to be a packed house? And thank everyone who's here online. I know how it is to be online because I was online 2 years in a row, and I'm here today, and I'm so excited to be here. My name is Jen Jones, and I am the founder of the Society for Sober Liver Survival. I'll talk a little bit about sober liver survival in just a bit, but I have a few slides to get through, and I want to get started because I've got some exciting information to share about advocacy for the most stigmatized liver disease, alcohol-associated liver disease. My disclosures are kind of more fun than a lot of the disclosures I've heard people just throw through today. I am integrating, and the Sober Liver is integrating with the Fatty Liver Foundation. And so I just started to be a paid contractor under them. And I'm so excited about this partnership. And if Beth could come up here on the stage, please. This is Beth Lehman, and I want to give some special thanks to Beth. She's our Sober Liver Strategic Survivor, Principal Strategic Survivor. She's a liver cancer and transplant survivor, and today she is going to be my Vanna. And thank you. Thank you, everyone. She has been just phenomenal, and we're a great team, and we're walking this path together, and it's been a great experience. I also want to thank some special people, too. I want to thank my mentor, Lorraine Steele, who is the CEO of the American Liver Foundation. I want to thank Dr. Shaw, who I will be talking about in just a moment. I want to thank Jessica Mellinger, and I want to thank all of these doctors that are going to be here today and talking to you today, because it's very interesting stuff. And Jessica is going to be the head of our WAC, which is the Whole Health Advisory Committee, but I need a co-lead, and I need one in psychiatry, so I think I have Dr. Weinreib to ask about that. So, and then I also want to thank the Fatty Liver Foundation again, and a special thanks to Wayne Eskridge, who is the head of the Fatty Liver Foundation and the founder. He's not here today, but he's healing, and we love him. And so, hi, Wayne. Does anyone in here know Latin? Okay, do you know what this word means? These 2 words, I mean.
Amor is in Spanish is love.
Right? Anybody else? Okay, it means love of fate. And Friedrich Nietzsche, sorry, hold on one second, who was a German philosopher, said that amor fati is the immense power of learning to love your fate. And I had to learn this the hard way. I am a survivor of severe intimate partner violence, and I developed post-traumatic stress disorder because of this violence. So I drank to numb myself. And there's a philosopher that started the Stoic philosophy who said he wrecked his ship to find his fortune. And he didn't find money, and I wrecked my ship too, and I didn't find money, but I found something that I think is so more special, which is my purpose. So when I almost died from liver disease on May 6, 2018, like many people with liver disease with alcohol-associated hepatitis and alcohol-induced cirrhosis that was decompensated, I only had a 30% shot for living, and I felt very ashamed. In fact, I was so ashamed that I asked my significant other. We were in Denver, Colorado. My parents were in Texas and California. I said, don't call my parents. Don't call my parents. And I could have died. And although I wouldn't have been feeling bad because I would have been dead, you know, how would my parents have felt if I would have done that? So that caused me shame after that shame. But my dog came to see me every day when I was in the hospital and in physical rehabilitation, which was about a month. He didn't take himself, he didn't drive himself. That'd be a whole nother story. My significant other brought him. But it was because of him that I found some purpose, because I wanted to live for him and I wanted him to live for me. And so when I got out of this whole fog, I needed to learn to love myself for all of me. And I think that patients need to learn how to love themselves for all of their experiences, and that is what Amor Fati is all about. But we cover ourselves in a basket of shame. And this basket of shame that you carry around starts to build up something inside of ourselves that's something that's just wanting to explode. And without empathy for ourselves, we need to disarm this basket of shame that's covered ourselves for so long. Vanna, please.
Here we go.
All right. And so what built up in me is self-stigma. So this is my tower of self-stigma that built up inside of me. And I want to break this down today. And, you know, I want to give a shout out. I don't know if she's in here today, but Wendy Lowe, anybody who was at the very first patient meeting that we had yesterday, she shared some amazing things about her journey. And we shared the same values. And as you will see, we shared, but she has Hep B and I have alcohol-associated liver disease. But we are connected because of these values that we share, and I think that that's because we have been doing this advocacy work and we have very, very much cultivated these values inside of ourselves. But what has been our foundation of shame? Vanna?
Which one's here?
The first one.
She made me do this.
Yes.
Does anybody have a drink? I didn't get it.
So what she's pulling out is the first side is fear, and we all have fear, but on the opposite end of fear we have courage. There we go. And then the second foundation of our fear is self-judgment. Self-judgment. We're totally self-critical about ourselves. And she can do it, she can do it. Woo! Woo! Self-judgment. But what's on the other side of self-judgment is compassion. But let's break this thing down. Let's break it down. What is next? What could be next? Okay, go ahead, Vanna.
Last time I did this, it was a drinking game.
I know. We all
right,
drinking
here we
Jenga. No, don't do it. It's more fun sober, I'm telling you, because.
Yes.
And, what happens? Down, up, and it topples down, and the final block is isolation. We all isolate ourselves from our friends, from our family, and what we really need is connection. And we build this connection, and this is where our vulnerability comes out, though. We have to, when we're vulnerable, we cultivate our courage. When we're vulnerable, we cultivate our compassion. We cultivate our connection. And that makes us resilient. So this was my first step of courage. I'm going to show my little courage bear. I'm a tiger, or lion, I mean, here. And so this is my lion, but you're seeing my dog at the time. That was my service dog, and that is Dr. Vijay Shah at the Mayo Clinic. I live in Denver, so I went to UC Health. And after almost a year of not drinking and finding out that there were no treatments associated for my condition, I'm like, where can I go? And I'm like, Mayo Clinic, I hear they do a lot of clinical research. So I did my own research, and I found Dr. Vijay Shah online, found he was the chief of gastroenterology. I'm like, he won't see me, and I spent nights writing a letter to him. He answered me the next morning. I remember I received an email from him at 6:30 in the morning, and I was like, oh my gosh, he's gonna see me. So I went on my first trip by myself to see him with my dog, but I hadn't flown alone in 5 years. And that was my first step in courage. And when I was there, he said, you're too healthy for clinical trials. He said, so you don't qualify for any clinical trials. He said, but you know what you qualify for? Advocacy. And he planted the seed of advocacy in me that day. And I started to move forward. I went back to school. I read a lot, and I started to get myself prepared for my next step in my journey. And this is where I'm here today, and this is my service dog now, and he is not with me. He is at home today because I had the courage to take this next step. And next time I'm going to have the courage not to bring my stuffed animals with me. So the next C is self-compassion. Does anyone know who Dr. Kristen Neff is? She has devoted her life, she's a good friend of Brene Brown's, by the way, and she has devoted her life to self-compassion. It's all of her work now. She's at the University of Texas, and she defines self-compassion as having mindfulness, kindness, and common humanity. Now, mindfulness has become a little cliche of a word for us today, but what the real meaning of mindfulness is keeping our emotions in balance. And going back to the amor fati, whether good or bad or indifferent, that we can look at the situation and we can stay present with it. And then kindness, How she talks about kindness is, how would you talk to your friend? Would you ever say that to your friend? Would you ever just say to your friend, you don't deserve to live? You don't deserve a transplant. You know, and the things that we say to ourselves are many times voices. Like for me, my voices are my abuser's voices. And so we have to learn to take a second, take a breath, step aside, and know that that is not who's talking. And you need to start talking to yourself with love and compassion. And then common humanity. Compassion means suffering with. And so we suffer with each other together, and so we all go through hard times. And so it's not only you, and once again, you're not alone. There's a yin and a yang to self-compassion. And this is my Care Bear, Tender Heart Bear. And there's the yin where you're all loving yourself and doing your self-care and everything, but then there's the yang, the bear, the bear. And this is where you're drawing the boundaries for yourself. You're saying, no, I don't want to do that, and yay, I'm going to try something new, right? And so this is where you need to be your fierce self and understand that that's okay, and love yourself through the process. And finally, connection. And this is another Brené Brown quote. Connection is why we are here. We are hardwired to connect with others. It's what gives us purpose and meaning to our lives, and without it, there is suffering. Now, everybody here, I gotta find my little prop here. Everyone here today is connected. We're all here today, and those of you that are online, you're connected with us through the cloud, right up here. But you're all here connected. But when we leave here, we're all still connected. And we need to remember this. We need to remember we are not alone. I'd like everyone to say out loud, I am not alone. I am not alone. Let's do it one more time. Come on. I am not alone. All right. Can we do it one more time? I am not alone. All right. Thank you for that. I appreciate it. Now, we've built up our nice little path. We didn't build it tall, because if we build it tall, it's going to crumble down. We're building a path that is present and forward. And this is where we get to our empowerment. This is where we become empowered, third eye, enlightened, patience. And so I would like all of the patients in the room to stand up, please. If you're a patient and you can and you're able to stand. Thank you. Oh, wow, we have very few patients in there. Okay, well, let's give them a hand. Okay, they had, and for those of you online that are out there that are patients, give yourself a hand, because we all have something in common. We had the courage to stop drinking, and we have one other thing in common. We came here. We are out there, and we are here to become the best advocates that we can be. So what I did is I decided that there was a gap. I knew that there were all these other liver organizations that were targeted, and they were getting together. They had community, and I'm like, we need community too. People with alcohol-associated liver disease need community, so I wanted to provide a space for that. And that's what Sober Liver is going to do, is we are going to be providing a place for that so people can have shame resilience, and we can break down that tower of self-stigma. And my motivation is that why that Wendy so eloquently talked about is that we are losing people at an alarming rate. And as Dr. Mellinger talked about today, she shared some of those alarming rates with you. I started to research things, and I got on the CDC Wonder database, and I became, quite the data person out of all of this. And what I found is we are losing people that are ages 25 to 44 because of COVID. From 2018 to 2021, look at these numbers. They're skyrocketing. And if you look at the populations, don't be fooled by these numbers. Like the Black population, that's because they are not getting the care that they need early enough, because we have lost trust in the doctors, the community has lost trust. And they need to see other doctors that look like them. And they need to have not accessible liquor stores on every corner, but they need accessible health care on every corner. So we need more accessibility for people that are in these communities instead of like shunning them and saying, oh, look, they're going to die anyway. So we need to have compassion. And then women. Women are dying at an alarming rate. Young women. And so that's I had a visceral response when I saw this. I'm going to start crying because every time I think about it, but that's my passion. So Congressman John Lewis said, if not us, then who? If not now, then when? Well, the now is here, the time is here, and together, what this meeting is about, together we are strong. So I want all the patients out there to think, what is your next step of courage? What is that small step that you can make? What is that next step? Thank you.
Thank you very much, Jen. That was super and very interesting, and providing us a perspective that we need to hear and haven't heard often enough. We're now going to hear from Professor Ramon Bateler from Barcelona, where he is the Jefe in Barcelona, very famous liver unit, and he has had a lifetime career moving forward the field of understanding the processes of and the treatment of liver disease related to alcohol. So it's a great pleasure to hear Ramon's perspective on an abstract tour.
Well, thank you, the organizers, and also thank you for this inspired talk. I cannot go directly to the abstract. It will be a pity not to say a couple words about patience. Yesterday, someone asked me, and I just tweeted it, what do you miss the most from the USA? And I was like, they came, my patients.